All right, good morning, everyone. Morning, everyone, and welcome to those visiting online as well. My name is Derek Rutherford, Director in the School of Physiotherapy and representative from our research committee who organizes these PT Matters sessions. So it's a pretty exciting day today for us where we have, once a year, we have our PT Matters sessions as student presentations from the students from the School of Physiotherapy. So it's a pretty exciting day where we have a PhD student, masters in our rehabilitation research programs, and our PT student, our graduate students in our physiotherapy program presenting today. So before I begin, I want to start with a land acknowledgement where Dalhousie University operates on the unceded territories of the Mi'kmaq, Wolastoqey, and Pasco-Makati peoples. These sovereign nations hold inherent rights as the original peoples of these lands, and we each carry collective obligations under the Peace and Friendship Treaties. Section 35 of the Constitution Act 1982 recognizes and affirms Aboriginal and treaty rights in Canada. We recognize that African Nova Scotians are a distinct people whose histories, legacies, and contributions have enriched that part of Mi'kma'ki known as Nova Scotia for over 400 years. So today we have, as I mentioned, a group of students. We're going to start with Meg Hannigan, who will present her talk on the role of pain sensitization and muscle function in knee osteoarthritis mechanics. Meg is a MSc rehabilitation research student under the supervision of Dr. Rebecca Moyer.
All right, thank you everyone so much for being here. I'm going to be presenting my thesis research today, and that's titled The Role of Pain Sensitization and Muscle Function in Knee Osteoarthritis Mechanics. So osteoarthritis is a degenerative joint disease which impacts over 4 million Canadians, and it's most commonly observed in the knee. Knee osteoarthritis is a leading cause of disability due to symptoms of pain and functional deficits that are associated with the disease. Though we typically associate the word arthritis with aging, there is a growing population of younger affected individuals who must be included in the research. To assess pain, one of the symptoms of arthritis, in a quantitative way, quantitative sensory testing can be used to look at pain sensitization or a heightened sensitivity to pain. A measure to do this is pressure pain threshold, so the pressure at which an individual begins to experience pain at any given location. One way to measure function in individuals with knee osteoarthritis is by looking at functional demand. One way to describe this is muscle capacity utilization, which is the proportion of an individual's total strength needed to complete a task. So for example, in this plot, if we look at that peak, so the most strength that they're using in the task, it's at about 0.2, showing that participants are using approximately 20% of their total knee extensor or quadricep strength during this walking task. Another way to look at function is through functional properties. So muscle function is related to the quality of the muscle tissue, which can be approximated using muscle stiffness. And muscle stiffness can be measured using ultrasound shear wave elastography, which one metric of that is shear wave velocity. This image here shows the rectus femoris muscle of an affected limb being measured by shear wave elastography. So what I wanted to do with my work was to look at how quantitative measures of the patient experience of pain and function might relate to one another to better understand the symptomatic presentation of osteoarthritis in the knee. So objectives 1 and 2 explored the association between pain sensitization and knee extensor functional demand, and pain sensitization and knee extensor functional properties. And then for objective 3, I wanted to include that younger affected group by exploring some age differences in these relations. So for hypotheses, it was hypothesized that there would be a negative association of PPT, pressure pain threshold, and MCU, which is muscle capacity utilization, and a positive association of PPT and shear wave velocity. Due to the impact of age on muscle function, it was also hypothesized that these correlations may be stronger in older adults. For the study, I recruited individuals with unilateral clinical knee osteoarthritis on the medial side of their knee using the American College of Rheumatology clinical guidelines. They had to be within this age range and have pain that was at least a 4 out of 10. They were excluded if they had bilateral symptoms or any lower limb pathologies or injuries that were current or recent, other than knee osteoarthritis. And if they were not able to safely complete the lab visit, they were also excluded. To assess pain, we used quantitative sensory testing using a pressure pain algometer to measure pressure pain threshold, and we tested at the distal radial ulnar joint, so the wrist, and then the medial joint line of both knees. To begin measuring our functional outcomes, we instrumented individuals with a retroreflective marker set for our passive motion capture system. Individuals then walked 10 trials across embedded force plates of walking, and then they did 5 stair ascents and 5 stair descents on a set of 3 instrumented steps. We collected their knee extensor or their quadriceps strength using an isometric dynamometer. We continued measuring function using functional properties, measured with shear wave elastography on a Logic P9 ultrasound unit. We tested locations of vastus medialis, vastus lateralis, and rectus femoris at the most prominent bulge of the muscle, and the measure that we collected was shear wave velocity. For our statistical analysis, we did descriptive statistics of the total group and then by age group. The age groups were under 50 years old and then 50 and above. And then we compared between tested locations using T, Mann-Whitney-U, and chi-squared tests. For our primary outcomes of pressure pain threshold, MCU, and shear wave velocity, we also did repeated measures ANOVAs with Bonferroni post hoc tests to compare between locations. For objectives 1 and 2, we used Pearson and Spearman correlations between pain and functional demand and pain and functional properties. And then for objective 3, we did descriptive statistics, again by age group, as well as linear regressions to compare age groups for all limbs, tasks, and locations. So this begins to describe my participant sample here. So I had 31 individuals who completed the study, 11 who were under the age of 50 and 20 who were 50 or over. There were no significant differences in sex distribution or BMI between groups, and the mean age of the sample was 52. So jumping into some plots here, looking at the results of pressure pain threshold over the total group, we found that the wrist, the distal radial ulnar joint, was significantly higher than the affected and contralateral knees, meaning that the wrist was less susceptible to pain through a pressure stimulus than either knee. However, we didn't find any significant differences between knees. For muscle capacity utilization, we found that MCU was higher on both stair tasks, significantly higher than the walking task, and that across all tasks we saw that values were higher in the contralateral limb, with significance being reached for both stair tasks. And then for shear wave velocity, we didn't find any significant differences between the affected and contralateral limbs, but we did find that the RF, the rectus femoris muscle, was stiffer than both the VM and the VL, and that difference reached significance for the VM. For objective 1, we did correlations between MCU and PPT for each functional task in the affected and contralateral limbs. We found that for all tasks, the correlations were negative, and that these correlations were steeper for the higher demand functional tasks of stair use than overground walking, suggesting that the relations may have been stronger in those high demand tasks. However, we did not reach statistical significance due to some small sample sizes and large confidence intervals. For objective 2, the correlations between shear wave velocity and pressure pain threshold, they were mixed for the affected limb, so small and positive for the VM, small and negative for the vastus lateralis, and then moderate and positive for the rectus femoris, and then they were pretty consistently small and positive for the contralateral limb. So jumping into objective 3, we wanted to look at how these associations differed between age groups. So due to the under 50 age group having only 11 participants, these associations are all exploratory. We can see here that in most conditions there is a negative slope. I'm sorry, the colors are a little bit confusing here. It's now the groups, so under 50 and over 50 are the colors, and then affected is above contralateral. So we can see that higher sensitivity to pain is associated with higher MCU or worse functional outcomes. We can also see that steeper slopes are present for the younger group, particularly in the affected limb stair ascent and the contralateral limb stair descent. And then comparing shear wave velocity and pressure pain thresholds by age group, we can see that most conditions, the associations are weak. However, there is a positive correlation for both age groups in the affected limb rectus femoris, suggesting that this may be an indicator of lower pressure pain thresholds or higher pain sensitivity. So jumping into some discussion here, for PPT, we found that there was higher sensitization in the knees than the wrist, and that the sensitization was present for both knees. This suggests that though individuals reported only unilateral pain to be eligible for the study, that they may have some evidence of osteoarthritis bilaterally, which is causing this sensitivity. For functional demand, we found that stair ascent and stair descent were more challenging functional tasks, which is supported by the literature. Particularly in the high demand functional tasks, individuals demonstrated higher MCU for the contralateral limb, and that suggests they may be implementing some compensatory gait patterns. And then for functional properties, we didn't find any significant differences between limbs, but the higher RF stiffness suggests that between muscle group differences might be present. For objective 1, we found that the association of higher pain sensitivity with higher functional demand was present across all tasks, suggesting that there is possibly a link between MCU and PPT, particularly during those stair conditions. This does align with our hypothesis that PPT is negatively associated with MCU. However, the large confidence intervals took away from that statistical significance. This finding is interesting, as previous literature did not find an association between between MCU and pain, but they didn't use quantitative sensory tests like PPT. They just used patient-reported measures instead. And then for objective 2, we found weak and inconsistent associations of VM and VL shear wave velocity with PPT, suggesting that there may not be meaningful correlations with these two muscles. However, finding this moderate positive correlation of affected limb PPT and RF stiffness suggests that RF stiffness may be associated with pain sensitivity. Lower stiffness may be associated with pain sensitivity. This was also consistent with our hypothesis. This was also consistent with our hypothesis and with previous literature that found that lower stiffness was associated with more pain. All right, and then some discussion for objective 3. In the relation between MCU and PPT, we found that for the younger group, we see that the affected limb and contralateral limb exhibit similar correlations in walking and stair ascent. But then when we look at the stair descent in the younger group, there was a steeper correlation there, suggesting that there might be a compensation specifically during stair descent, which is a commonly reported challenge for individuals with early stage knee osteoarthritis. Then for the older group, we found very little difference between limbs, but we did find a pattern that as the tasks became more challenging, from walking to stair ascent to stair descent, that those associations became stronger. So that suggests that that relation for the older group may become stronger as tasks become more difficult. And then for age in shear wave velocity and PPT, we found mostly that the RF has the strongest relation, and that was consistent in both the younger and older group, but that the younger group was actually steeper. So showing that some of the younger group correlations were stronger, that did not align with our hypothesis for objective 3. So what does this imply? The association between pain sensitization and MCU may be used to explore pain's contributions to compensatory gait patterns, especially in those high-load stair activities. Rectus femoris, or RF stiffness, is lower when pain is present, and clinically this may imply that looking into strengthening RF may help reduce pain, but that will need more research. And then the preliminary exploration of age groups between pain and function suggests that there are age-related differences, and clinically this implies that we may want to treat individuals who are younger or older differently with prescribed physio treatment plans. I'd like to acknowledge my study participants who volunteered their time for this study, my supervisor, Dr. Rebecca Moyer, and my Dome Lab colleagues. Thank you.
For the sake of time, we're going to move to the next presentation. Not that you were over, but I just feel like we're going to... Yeah, no worries. For the sake of time, we're going to move to the next presentation, but I will let you know that Megan is defending her thesis on this topic in June 25th, so there will be a time for you all to come and listen in on Megan's thesis defense. So thank you very much again, Megan.